Here, we will be focused about your objective assessment. So, in your gathering of objective data, when it comes to your ear assessment, take note that we are assessing the ears, nose, and the throat. Okay, the involvement of these organs, or due to the close proximal placement, or to a close proximity, of these organs, problems of the ears could possibly affect the nose and the throat, and vice versa. Okay, we perform your otoscopic examination. Remember, your otoscope is the one that could visualize your ears. And then we also assess the temporomandibular joints. This is where your ears are closely placed. So when I talk about your temporal bone, remember that part of your middle ear going towards your inner ear are already enclosed in your temporal bone. Then you also palpate the sinuses. Then you check the mouth and the oropharynx for the possibility of infection, because it could also manifest to your ear in relation to the location of your cranial nerve number 7, your facial nerve. Commonly, when we are doing assessment of the ear, what we commonly use is your inspection and palpation, okay, especially on your sinuses. This is your otoscope, and these are the different sizes of the probe that can be used to assess your patient. So that would be depending whether your patient is a pediatric or an adult patient. So the different auditory screening tests. One is your whisper test. So class, when we are doing our whisper test, the preparation is, number one, to instruct the patient to cover the untested ear with a palm. So it's either you tell the patient to cover it with the palm, or you ask the patient to press through the tragus. Okay, so the patient should press against the tragus so that it will be the examined ear that will be able to hear the sound. And usually your patient, as an examiner, you will be standing 1 to 2 feet away from the patient, and then you should be out of the patient's sight, and that is to ensure that the patient will not be able to lip read. The second test is the watch test. So it's referred to as watch test because basically you will be asking the patient to listen to the ticking of your watch. And then the third one is your audioscopy, and that is with the aid of your otoscope, okay, the visualization of your auditory canal or your middle ear structures. So take note that if you're using your otoscope, we can only visualize up to the tympanic membrane, up to the middle ear if the tympanic membrane is already perforated. Okay, so this is your otoscope. This one is attached to a light source. Okay, you might be wondering what is this tubing here. Class, this is just a type of otoscope which is hung through the wall, especially if you are in settings like that of abroad. Okay, there is also an otoscope which can be connected to the computer, which would aid on the visualization. Now, recall the technique on visualization of your external auditory canal. So that would be to pull back and downwards if we're dealing with child, and then that will be to pull back and upwards if we're dealing with an adult. Okay, so remember that who do we consider child for this one are those who are 3 years and younger. So what is our preparation prior to the test? So prior to otoscopic examination, we need to ensure that there should be our ears should be free from large amount of cerumen. So if there's a large amount of cerumen there, a warm water may be used, mineral oil may be used, over-the-counter cerumen softener may be used. Okay, but cerumen curette, if ever needs to be done, should be done by a doctor or a physician for that matter. So class, this is your tympanic membrane under the otoscope. So recall earlier on the previous lecture that when you are viewing class your tympanic membrane along with under the otoscope, you should be able to see the anatomical landmarks. So these are already your ossicles class. No? Recall that your ossicles are the 3 small bones. So particularly this is already your malleus, okay, and part of your incus, and then part of your stapes. Okay, so class, this is your light reflex, which can be seen when this part is lighted or illuminated by the light source of your otoscope. Okay, so this would indicate that this is a normal tympanic membrane. Now, you have your Weber test. Class, your Weber test is the test for the lateralization of sound. Okay, class, when I will be performing your Weber test and your Rene test, the equipment that you will be using is your tuning fork. Okay, your tuning fork. Now, before you use the tuning fork, class, you would usually have the tuning fork, okay, or you would hit the tuning fork on your palm, the purpose of which is for the tuning fork to vibrate. If you're doing your Weber test, you will be placing your tuning fork here. Okay, so your tuning fork will be placed here. The purpose of that class is to test for lateralization of the sound. So class, once you will place your tuning fork, let's say for example, placing your tuning fork here class, you'll be asking your patient, okay, on what part or on what ear is he hearing the sound louder? Okay, so class, if the patient will be hearing the vibratory sound okay, on the left ear or the right ear louder, that would mean an abnormal result. Okay, because the normal result is that once you place your tuning fork here, once you place the vibrating tuning fork here, it should be equal in both ears or it should be centered. If your patient is having conductive hearing loss, it should be, the sound should be better in the affected ear. Again, if your patient is hearing or having conductive hearing loss, it should be better in the affected ear. On the other hand, if your patient is having sensory neural hearing loss, he should be hearing louder in the unaffected ear. He should be hearing louder in the unaffected ear because of nerve damage. Okay? Again, conductive hearing loss, the patient will be hearing the vibratory sound on the affected ear, louder on the affected ear. So recall that your conductive hearing loss is caused by your otosclerosis, otitis media, or any problem with your external and your middle ear. On the other hand, your sensory neural hearing loss is caused by problems on nerve damage. So class, if your patient has a nerve damage, he will be hearing well on the unaffected ear when it comes to your Weber test. Okay, he will be hearing better on the unaffected ear when it comes to your Weber test. For us to have the application of your Weber test and Rene test, allow me to give you an overview of the common disorders of your external ear, middle ear, and your inner ear. So class, for your external ear, you would have your impacted cerumen. So you know that your impacted cerumen will be basically what we commonly refer to as bulaho in our setting. Okay, here, foreign bodies. So if you have foreign bodies, for example, vegetables, okay, some objects inserted there by children, and then your external otitis. So external otitis common among swimmers. Okay, I don't know if you've experienced that. Severe ear pain after you have been swimming for long. Okay, so that's external otitis. And then for your middle ear, you would have otitis media. So middle ear otitis. You have your serous otitis. Serous as in there are a lot of fluids. Otosclerosis, the hardening of your ossicles. Tympanic membrane trauma, when your tympanic membrane will be destroyed. Cholesteatoma and acoustic neuroma are abnormal growth here, okay, in the middle ear. And then in the inner ear, you have your Meniere's disease. So class, Meniere's disease is increase of fluids, okay, in your inner ear. Then you have your noise-induced hearing loss. Presbycusis. So presbycusis, changes related to aging that damages your inner ear. Ototoxicity caused by your drugs. So that's your inner ear structures which are damaged here. Okay, now let's try to apply your Weber test. So earlier in Weber test, I told you that it is intended to test for lateralization of sound. And then when I say that it is conductive hearing loss, it would be, the findings will be that the patient will hear better on the affected ear. Okay, let's try this as an example. Picture a patient with an impacted cerumen in the right ear. Okay, impacted cerumen in the right ear. When I will be doing the Weber's test, where do you think will be the lateralization of the sound? Will it be on the right ear or will it be on the left ear? Try to think. Okay, now, I said impacted cerumen. So class, when I say impacted cerumen, is it conductive or sensory neural hearing loss? It's conductive hearing loss. Because it's conductive hearing loss, okay, where do you think will the sound be louder when I'm doing the Weber's test? It will be louder on the right ear, on the affected ear. Good on that. Let's try. I have a patient who is having Meniere's disease, which is prominent on the left ear. Left ear. Where do you think will be the sound of your Weber's test lateralized? Will it be at the left ear or the right ear? It will be at the right ear. How come? Recall that your Meniere's disease is an inner ear problem. As an inner ear problem, it is sensory neural hearing loss. When I say sensory neural hearing loss, the lateralization of the sound will be louder on the unaffected ear. In this case, class, the damaged ear is your left ear, and then your unaffected ear will be your right ear. Hence, in this sensory type of hearing loss, it will be louder on the right ear. Okay, so try to explore deeper on those concepts as we go along. Then we have your Rinne test. Some of you will pronounce this as Rhine test. Okay, Rinne test. Plus, the purpose of your Rinne test is to compare bone conduction and air conduction. Recall that I have mentioned that there are two ways for sound to be transmitted to our inner ear. One is through bone conduction, and then the other one is air conduction. The common ones, for example, the one that you're using right now when you are listening to this recorded lecture through your laptops, is your air conduction. From the speaker of your laptop, it would travel to your ear. That's air conduction. But if there's an object which is placed class near on your bone here, okay, for example, bones here, okay, bone here, and then you'll be hearing the sound, okay, you'll have your bone conduction. That's your bone conduction. Okay, equipment used is still your tuning fork. There are two procedures that needs to be done here. One, to place the vibrating tuning fork on the mastoid bone. That would just be behind your ear. And then, once your patient will say, I could not hear the vibrations anymore, place it 2 inches from the opening of the ear canal. Okay, 2 inches from the opening of the ear canal. Okay, again, first step, vibrate first the tuning fork, and then place it against the mastoid bone. Instruct your patient to listen to the vibratory sounds. Once the vibration is gone, your patient should inform you. And once the patient informs you, you should transfer your tuning fork here. Once class the tuning fork is transferred here, normally, the patient should still be hearing the vibration. Because the normal result of your Rinne test is that air conduction is longer than your bone conduction. Again, air conduction is longer than your bone conduction. Usually, class, it's twice as long as your bone conduction. Okay, so this is bone conduction test on the mastoid process, and then this will be your air conduction test here on your outside of your ear. Of course, class, your patient will not be using the headphones during the test. Okay, now, abnormal findings. If your patient is having conductive hearing loss, it will be bone conduction, which is longer than air conduction. Again, in conductive hearing loss, bone conduction will be longer than air conduction, which would mean that I will be placing it here. Okay, it's vibrating. Your patient could hear. By the time your patient will say stop, and if your patient would have bone conduction, or I mean if your patient has conductive hearing loss, the tendency is by the time you transfer the tuning fork here, your patient could not hear anymore any vibratory sound. That would indicate that the bone conduction is longer than the air conduction. Suspecting I mean your conductive hearing loss. Okay? So, try to apply. For example, if I had, for example, Rinne test on the left ear, by the time I transferred it here, the patient is not hearing the sound. What would I suspect? Is my patient having presbycusis or otosclerosis? You should suspect presence of otosclerosis because that would signal class the presence of your conductive hearing loss. So that is how you apply your Rinne test and your Weber test. Okay, class, in addition to your Rinne test, another abnormal finding is that if it is sensory neural hearing loss, the tendency is that air conduction will be more than bone conduction. However, not twice. Okay, and then if you would want to confirm sensory neural hearing loss using Rinne test, you need to do further testing. Okay, but we are sure that in conductive hearing loss, the bone conduction will be greater than your air conduction. I hope that enlightens you. Now, to compare to, okay, so this is your Weber test done, test for lateralization of sound. This one is your Rinne test, okay, the first step for your Rinne test. Okay, class, by the way, your tuning fork has different sizes. Particularly, there are 3 in a set. The smaller it is, class, the lesser the decibel. Okay, remember that decibel is the measure of sound. So, the bigger the tuning fork, the higher the decibels. So class, this is to compare your hearing status when it comes to your Weber test and then your Rinne test. So class, normally, when I'll be doing the Weber test again, the sound will be heard equally in both ears. Equal. Okay? In conductive hearing loss class, the sound is heard best in the affected ear, assuming it's the right which is affected this time. If it is sensory neural hearing loss, the vibratory sound could be heard properly on the normal ear. Okay, on the normal ear. Okay, now on Rene test. Class in Rene test, normally, class in Rene test, air conduction is audible longer than your bone conduction. That's why the symbol AC is greater than your bone conduction. Whereas in your conductive hearing loss, okay, the sound is heard as long or longer than in affected ear. In other words, the bone conduction class is longer than your air conduction. Whereas in your sensory neural hearing loss might be confusing, but the air conduction is audible longer than your bone conduction in affected ear. So again, I mentioned earlier that this is non-specific to your sensory neural hearing loss. Okay, need to do further testing if you would want to use Rene test for sensory neural hearing loss. Now, audiometry. There are two kinds of audiometry. You have your pure tone audiometry and then your speech audiometry. Pure tone audiometry class, I'm placing the patient using earphones inside a soundproof room, and then this patient will be telling us if ever he's hearing the tone. Okay, so class in pure tone audiometry, what is being used is a pure or musical tone of music. Whereas on your speech audiometry, obviously speech audiometry, so it's the speech which is being used. Okay, class CT scan and MRI. CT scan and MRI are imaging studies, not routinely done for ear examination, but done if we are ruling out other concerns on your ear problems. Okay, let's say, for example, we have this patient with hearing loss and then we do not know what's the primary reason. The ENT could not find out the primary reason for that. Okay, so class CT scan can be done. CT scan is used class best to rule out acoustic neuroma. Again, acoustic neuroma, or also known as your vestibular schwannoma. Okay, schwannoma. This is actually class non-cancerous, but this is a tumor that would develop from the vestibular nerve, usually arising pa class from the middle ear going towards your brain. Okay, middle ear, inner ear going towards your brain. Okay, so class, if you would look at this illustration here, this is actually your ear and then the tumor is growing. Okay, so here's the tumor. Okay, it's a slow-growing tumor. Best visualized using your CT scan. So this view class is this plane of your head. Okay, it's a cross-sectional cut of your head. Then class, you have your MRI. So class, your MRI is also used for assessment of your tumors. Okay, class, it is the test of choice for tumors of your temporal bone. Okay, it's hard class to visualize tumors in the temporal bone if we will be using your CT scan. So MRI would give us more detailed images. Okay, so class, this is actually showing tumors arising from the temporal bone. And then for the invasive test, so we have your culture and sensi, especially class if we're dealing with chronic otitis. So we need to have cultures class to identify the organisms and then sensitivity to identify the proper antibiotic. Then you have your arteriography and then your venography, arterial, of course, for the arteries, venography class for the veins. So basically the purpose is to check for the vascular abnormalities, especially that going to your temporal bone. And then your caloric testing is used to evaluate the vestibular portion of your cranial nerve number 8, your auditory nerve. Okay, so class, this one is arteriography and venography image. So arteriography, venography, there is a use of your contrast media. And then your, imaging studies. So you'll have your CT scan to evaluate the structure of your head. So particularly class blood flow going towards your temporal bone. This image class shows an impaired blood flow going to this part. Okay, as you can see, there is narrowing there of the blood vessels. And then this one would be showing your caloric testing. So class, when I say caloric testing, recall that this is the placement of cold or warm solution going towards your ear, wherein we expect nystagmus. Okay, so class, caloric testing, light meals before test, or preferably class NPO if needed. Why? The patient may experience nausea and vomiting. During the test class, the patient may be on sitting or supine position, usually class supine position. The procedure is that there is irrigation of cold and warm solution into the ear, and we are noting for nystagmus. So class, in this case here, it is this device who will be capturing for the nystagmus. Okay? Then class, the normal finding is that the patient will experience vertigo and nystagmus that would last for about 20 to 30 seconds. Class, your caloric testing is actually already a test for your inner ear functioning, because If you can recall, your vestibule is already located on the inner ear. So again, the normal finding is that there is presence of nystagmus. So that's your caloric testing. Okay, so class, normal findings in your ear assessment, just as a summary, the ear should be symmetric, it should be aligned to your outer canthus, able to hear 3 out of 3 words in whisper test. The auricle here and the tragus should be non-tender without lesions. The canal should be clear. Then class, the tympanic membrane should be intact. Landmarks and light reflex should be intact. Weber test should be in the center or equal. In other words, no lateralization. And the Rene test would have air conduction, which is longer than your bone conduction. Twice, oftentimes twice. Class, that will be the end of our discussion on the assessment of your ears. Okay, we'll have your next discussion on the disorders already of the external ear. Once again, reminding you to laugh a little louder and dream a little bigger. Thank you for your attention.